Welcome to the Acute Medical Teaching Series. We are your hosts,
Shifona
and Harrison, both senior house officers from Salisbury District Hospital. This is a 12-part teaching series running over the next 3 months. You can find links to the other sessions on our YouTube channel or via Blackboard for the local Southampton students. This is our 11th session, and we will be looking at asthma exacerbations today.
So what is an asthma exacerbation? An asthma exacerbation is broadly defined as an acute exacerbation of asthma symptoms associated with features such as increasing shortness of breath, cough, chest tightness, and wheeze. We know it is generally triggered by an environmental cause, with respiratory viruses being an important cause, but also includes exposure to allergens and irritants.
Around 12% of the population in the UK have asthma, with 60,000 hospital admissions per year. And globally, approximately 180,000 deaths can be attributed to asthma annually, with most deaths being preventable. So how does an asthma exacerbation typically present? You'd expect to see a person present with a background of asthma, although note this may be the first presentation and therefore this would be undiagnosed. And then we talk about the classic triad of an asthma exacerbation being worsening shortness of breath, cough and wheeze.
They may also complain of excessive chest tightness, and they may have underlying risk factors for an exacerbation. For example, exposure to unwell contacts, increasing age, poor asthma control or prior exacerbations, smoking, and obesity. Their peak flow will also be reduced from their best. You can use peak flow to help categorize the severity of the asthma exacerbation, with less than 33% of the peak expiratory flow indicating a life-threatening asthma exacerbation. Although, note, in the acute setting, the PEF can be difficult to interpret, especially if the patient is tired or non-compliant. So you must not solely base your assessment on this.
On examination, you may see evidence of tachypnea and tachycardia. You also need to be aware of the examination findings that indicate a life-threatening asthma exacerbation, which is important not to miss. These include symptoms such as a silent chest, where you hear quiet breath sounds on auscultation of the chest, cyanosis, poor respiratory effort, hypotension, and then we'd also expect to see an exhausted patient and sometimes an altered level of consciousness. On pulse oximetry, their SATs would be less than 92% and their peak flow would be less than 33%, although note, obviously, the previous caveats apply.
So how would we go about investigating an asthma exacerbation? If the patient has any features indicating a life-threatening asthma exacerbation that we talked about previously, you need to measure the arterial blood gas. At this point, you do not need any other immediate investigations to start the management. When interpreting the ABG, we look at the oxygen saturations. If the oxygen saturations are less than 92%, this confirms a life-threatening exacerbation. It's also important to look at the carbon dioxide levels and the pH. A normal CO2 indicates a life-threatening asthma exacerbation, as the patient should be blowing off the carbon dioxide as they hyperventilate, and indicates that the patient might be beginning to get tired. A raised CO2 indicates a near-fatal exacerbation for this reason.
As we mentioned previously, peak flows can also be used to grade the severity of asthma exacerbations, and that key cutoff being less than 33% indicating a life-threatening asthma exacerbation. We know, however, if it's in the range of 50 to 75%, this indicates a moderate asthma exacerbation, and then 33 to 50% indicates a severe asthma exacerbation. However, as we've said before, peak flows are very effort dependent and can be very variable, so do not solely base your clinical assessment on these. And we can also use peak flows to interpret a patient's response to treatment. So if we see a significant improvement in their peak flow, this means that they've got good bronchodilation and we're getting on top of the asthma exacerbation.
Other routine investigations to consider include blood work, for example, full blood count, CRP and U's, chest X-ray and ECG. Don't forget to check the theophylline levels if the patient is on oral theophylline. So what is our differential diagnoses for acute asthma? Important diagnoses to consider include pneumonias, COPD, PEs, pneumothorax, heart failure, or even ACS and foreign body obstructions.
So how do we go about managing an acute asthma exacerbation? We'd want to start them on oxygen therapy. We'd also consider starting salbutamol nebulizers. So these are bronchodilators, and these will expand the airways. And generally we use 2.5 milligram of salbutamol. We note historically used to use 5 milligrams, but we found that makes patients too tachycardic, and we find 2.5 milligrams is a good middle ground. If they're not responding to this treatment, we can then consider therapies like ipratropium nebulizers, where the dose is 500 micrograms QDS. We'd also consider starting them on a steroid, so you can use IV hydrocortisone or you can use oral prednisolone. Both are equally as effective as each other, and generally we'd be doing a 5-day course of these. If they're still not responding to nebulizer therapy, we'd then consider magnesium sulfate, and this would be 2 grams IV over 20 minutes. And then if they're still not responding to this, we'd be looking to escalate to ITU, or we'd be looking to start an amnoflurine infusion. Although note with amnoflurine infusions, they're very controversial with a poor evidence base, and some clinicians advise avoiding them. Those with acute, severe or life-threatening asthma may require ventilatory support in the long run, so it's good to get early ITU involvement, especially for life-threatening asthma exacerbations. On the screen now you can see the BTS guidelines on the management of asthma exacerbations. You can find these on the BTS website, and they're a very useful guide on how to approach these situations. So what follow-up do we need for these patients? Once we get on top of their asthma exacerbation and we're looking towards discharge, we need to consider educating the patients on how to monitor their symptoms. Also, for particularly difficult to control asthma, we may develop an asthma action plan. And generally, once we're discharging these patients, we normally signpost them towards their GP for a follow-up, and most GP practices nowadays have an asthma nurse specialist.
Thank you for watching. Don't forget to fill out the feedback form in the description below. We are your hosts, Shifona
And Harrison.
See you next time.